Okay. Well, I think then in that case, have we got this all wrong? Has Anthony got this wrong? Have I got this wrong? Should we just be saying to Marcus, please, these people just need an operation and then they'll be cured and all this is nonsense? So I'm going to hand you over to Marcus Reddy, consultant upper GI surgeon at St George's, who's got a very big reflux-based practice, and I'm looking forward to hearing what he has to say.
Thanks, Kinesh. Let me just check that you can hear me and that you have video now. I'm going to share a screen. If you can activate that, please, Anthony, so I can do screen sharing. Are we able to activate the screen sharing?
It's done.
Done. Okay, great. Great. Okay. Right. Can you see that? Kinesh, is that visible, the screen sharing?
No, not yet.
Okay, why has that not come up? Okay. Share. Is that sharing?
Yeah. I've got your whole screen. Yeah.
Yeah. Is that good?
Perfect. Thanks so much.
Yeah, thank you. There's so much science going on from Anthony and Kinesh, and surgery, you know, lots of the things we do are quite slightly less scientific. I think the tradition of the fundoplication, which has been going on for 60 years plus, we still don't have really strong randomized control trials with all the other techniques, but there's definitely been a massive resurgence for thinking about other options, in particular endoscopic. And that's because over time there's been development from the old assumption that basically you either use PPIs for GERD or LPR, which obviously more recently we now know that for LPR it's less useful, PPIs, or you go down the surgical route. That's been the traditional view. But obviously the last 15, 20 years, we've seen more and more concern about the use of PPIs, which has made people consider much more the option of undergoing an intervention. And as a result, there've been a lot more development. So a lot of people have heard about the obviously complications of reflux surgery, which there are many side effects and complications. And the follow-up for the Nissen shows that there's also a durability issue, because it's not just good at controlling reflux for a short while, but over years it seems to hold, and then ultimately over many years it really does become much less successful. So I think the option of surgery, it's still appropriate in some patients, but we have to be aware of all the side effects, complications, and the durability issue. And I think a lot of the data that surgeons have been looking at is using the traditional HRQL type questionnaires, which is predominantly traditional GORD type symptoms. So when we follow them up, we use these rather than the RSI, which is much more LPR type symptoms and throat type symptoms, where the patients have cough and hoarse voice and these types of symptoms, which obviously are much more difficult to manage. But I think because we've grouped it all together, the outcomes, we don't distinguish very well with interventions between LPR and classic GORD symptoms. And ultimately people have thought, well, what's the alternative? Well, the principle of the Nissens effectively is to correct any diaphragmatic, so external weaknesses, and which is effectively the external lower esophageal sphincter. And the link similarly is about reducing these transient relaxations of the lower esophageal sphincter from external. And I'll talk a bit about stretta, which is much more about the internal muscle development, all really trying to, I think, try and control these transient relaxations which occur and allow reflux to come up. I mean, the other issue is probably gastric emptying, which we know is significantly associated in reflux patients and will promote reflux as well, especially during these transient relaxations. So the Nissen, ideally, we believe helps create a new sphincter. It's not quite a one-way valve, and we all know of patients who have significant dysphagia weight loss, bloating, but it does control reflux really quite well. The reason of all these other things like links and strata and TIFs and all these endoscopic techniques exist is ultimately because the nissen isn't perfect based on its side effects, complications, and durability. There are problems with links as well, of course, which can involve the actual foreign body device either not being fixed in the open position because of scarring and leading to ongoing reflux, or in the closed position, where it would of course develop dysphagia, but it can slip as well in the road. So it's neither, that's not perfect either. But we do know that when you compare them, they do have fairly good control of pathological reflux compared to each other. I think that the side effect profile is quite different. And of course, all this data really is HRQL, which doesn't separate the throat type symptoms, the ones which the patients may complain of with hoarse voice and sore throat or postnasal drip type symptoms. But we can see that really the HRQLs of both have fairly good long-term follow-up. We don't have such good data quite for strata, but it's still more than 10 years worth of strata data now. But we can see, compared to using PPIs, it's not bad at doing anti-reflux surgery. I'd say that strata, where we do an endoscopy and put radiofrequency into the lower esophageal sphincter, above and below the junction level and in the cardia, works primarily on the sort of submucosal area where there's probably some degree of fibrosis and some muscularis hypertrophy of the internal sphincter. And I think that most of us would believe that its function really is primarily to reduce these transient relaxations, which help promote reflux. And there have been some interesting studies to show the levels within the wall of the esophagus about the hypertrophy of the muscle before and after strata. It takes many months, so patients often get a transient improvement for a few weeks after the procedure because they have some temporary edema, I think, from the needles, and then that settles and their reflux comes back, and then they go on to get improvement. And when we say improvement of reflux, that can be reduction in medication, better control on medication, and less so coming off medication. I'd say that my experience, it's more about 30% will actually come off medication, but they will, 3/4 will get improvement in some way. So we can see the high degree of hypertrophy you see within the internal sphincter layer. So there is quite good data going over a decade now for strata, but if you look at most of the data is actually all, in a way, traditional Gord type quality of life surveys. We don't really have quite the same quality when it comes to the throat type symptoms. It's not separated well, but it is believed that, for example, there's some good data now supporting strata for LPR as well. But I see strata, part of it sits between this medication and surgery. It's not necessarily an alternative to surgery, especially if they've got a hiatus hernia, who I think that surgery still significantly helps those patients. I mean, it's been reviewed endlessly, and I think strata now has got fairly good support, having been considered a bit experimental and novel. It's now part of the repertoire of procedures for reflux, and in the US, it's been used over 250,000 times, I understand. But I think that it's still in its early days from the point of view of knowing its exact role, whether it's used in isolation, together with PPIs, bridging between surgery. I think it does have a role, but I think we have to be selective at this stage with strata. And, I tend to select patients according to standard reflux, pathological reflux on pH manometry. I'm always cautious about the LPR patients, and I will warn them that I feel it's significantly less successful for LPR, even though some of Professor De Guerra, who's done over many thousands in Italy, would strongly support it for LPR. I'd say it definitely doesn't, in my hands, have the same success rate as for classic reflux symptoms. But you can use it after fundoplication, which is quite useful. Patients who've had fundoplication many years before, I do use it sometimes if they're finding that they are now getting recurrent reflux. It's proven not to be useful in the bariatric patients. I think that bariatric surgery changes the anatomy and physiology of the upper gut so significantly, it's hard to assess any role for stretta in post sleeve or bypass patients with reflux. And there's certain patients you wouldn't use it in, and specifically it's the hiatus hernia patients who've got significant diaphragmatic defects. I'd be reluctant to use stretta. But I think its role fits somewhere within the range of bridging between PPIs and surgery. Obviously, the number of patients wanting to come off PPIs has meant a lot of slightly optimistic and hopeful thinking that stretta would get them all off it, but it doesn't for a lot of patients. They often get better control, but it doesn't get them off their PPIs often. So we've tried bariatric patients and I've had no success with it. And I don't think many people have either. So my personal strategy is patients with the significant hiatal defects where there's anatomical disruption. I think that they need an anatomically correcting procedure in the hope that it improves the function. The LINX patients, I've actually started using in patients with bigger hiatus hernias now that it's much more established. You know, there have been people who use it post-bariatrics. I tend not to, because I think that there are usually other reasons in bariatric patients why they're refluxing, such as degree of stricture formation or angulation in the stomach, which reduces the gastric emptying. So I think that using LINX and that should be done with caution. And stretta is useful in those who can't or won't have surgery. But I think that giving them the expectation is extremely important, whether they're going to get a good success or not, because even though it's non-invasive, I think there's clearly a group who won't benefit. We've been using it with Kinesh's assessment in patients with lung transplant with some success. So I'll just mention TIFs because there is transoral incisionless fundoplication surgery happening in London. And I think it's still at its relatively early stage, but I think it may well have a role in future. It can't be used in revision because of any distortion in the anatomy. But I think it's one technique which, you know, I'm watching closely as a potential future endoscopic technique, which also does some anatomical correction, which stretta can't. Any questions?
Marcus, while people are thinking, there's two things there. I mean, you know, this mechanism of you know, which I talked about you know, right-sided colon increasing the sensitivity to transient lower esophageal sphincter relaxations and so forth, is exactly why I think stretta has always, the company itself has always paired with Restek. So they've always thought that there was this kind of pepsin-related disease, and in fact, in America now they have the pepsin thing. So they've kind of pushed this hypothesis without putting any science behind it. Are you aware of any studies that are kind of ongoing or are in the pipeline to kind of, you know, tie together the physiology with the outcomes from stretta rather than, you know, beyond the typical kind of reflux measurements?
Yeah, I mean, nearly all of it is still about quality of life surveys and like the RSI questionnaires. I think the transient relaxation, the problem is it's delivered in different ways in different countries. And I think that where stretta has been used, for example, in parts of Europe where it's prescribed, so there are parts of Europe where patients on PPIs who want to come off can be prescribed to go and have a stretta. It's not led to very good data beyond quality of life surveys. And the physiological studies have been fairly lacking. But I think it's going to be time before we get good data on stretta more than quality of life surveys. But I think for the, I think the strategy of seeing it as part of sort of managed investigation assessment, including, for example, breath testing and dietary change, especially for the LPR patients, really useful. But I don't think we can see stretta as, you know, the sort of as a primary treatment at the moment. I think that they need a lot of assessment before. I mean, usually these patients who come for Stretta will be partly managed with dietary change, low FODMAP. They will have breath testing, and many of them have LPR, and they're looking for a non-surgical procedure. So, if you could do some more work on it, it'd be really helpful.
Yeah, no, I think that's the point, because at the moment it's fail on PPIs, go to the surgeon. And I think that's the work that we've done with, some of our upper GI surgery colleagues, is to try and understand a bit better about patient selection. Because, if the number one symptom or number two symptom after Nissen fundoplication is gas bloat, then is it just due to the mechanical obstruction, or is it just because they're producing too much gas? And people hadn't really thought of it in that way before. And it's just trying to engage our brains a bit more about, that patient selection process. But doing any kind of randomized controlled trial with these different mechanisms and including physiology is so incredibly difficult and laborious that it remains challenging.
Yeah, I think that it strongly supports the sort of MDT approach with physicians and surgeons working together, because it's quite easy for a patient to jump from PPIs to asking for a surgical opinion, when actually, the thorough workup, going through all the options, including all the different interventional options, is really helpful. And I think some of these patients, I'm sure you've seen them with SIBO, and who've actually done quite well with non-interventional methods of management. Or patients who've had surgery and actually subsequently do quite well once they've been fine-tuned with diet and sometimes antibiotics and sort of non-surgical interventions.
So just to keep the physiology thing rolling, you mentioned a little bit about gastric emptying. There's been quite a few studies recently that have kind of said that gastric emptying testing, is either fast, slow, or normal, but doesn't, correspond very well with symptoms and everything else. How do you use gastric emptying in terms of, predicting outcomes for surgery? Do you look at things like pyloric outflow and is it due to the hiatal defects? How do you use sort of gastric measurements to sort of help with your patients for surgery?
Sadly, most of the time it's an afterthought after surgery when they develop side effects of gas bloat, or they don't respond well to the anti-reflux procedure that most of us then start investigating. I think if there are clues prior to considering an intervention, then it is useful to do gastric emptying studies, even though there's a big variation in norm. The traditional gastric emptying studies, I think that because of the wide range of whether they're truly delayed or not, is still difficult for us to really interpret. Some patients will be having surgery when they have gastric emptying problems, and that inevitably leads to either poor reflux control, for example, after Nissen. But there's some evidence, strangely, that Nissens actually improve gastric emptying, even though you'd think to the contrary. At the same time, most patients, I think, who have Stretta also seem to have some slow emptying afterwards. But we don't normally investigate gastric emptying as part of their workup, but I think maybe we should be considering it much more often before we commit them to a procedure. Kinesh, how do you, before you consider referral for intervention, try and pick up those who've got poor gastric function?
So I think because a lot of the patients I send to you have cystic fibrosis and diabetes, and is often poorly controlled and have had it for a long time, the high index of suspicion in that cohort. I think if there are no upper GI symptoms in a sort of standard patient, then I'm not overly suspicious. But in that group, I think if there are symptoms of early satiety, vomiting, or just heaviness, postprandial heaviness, then I think now I have a fairly low threshold for doing gastric emptying study, just so we can inform the patient a bit more about the risks of surgery and what that may entail if things don't quite go according to plan. Because
I think that if we consider the transient relaxations, in those patients with any degree of gastric emptying problems, they are going to have quite exaggerated symptoms, aren't they? And potentially they will be the high-risk patients for gas bloat.
And that's one of the reasons that I think, in cystic fibrosis particularly, where bloating is the #1 gastrointestinal symptom overall, and that's why fundoplication is not a good option. In the groups, people, the cystic fibrosis groups, they're saying don't have a fundoplication, to each other.
Yeah. I mean, one thing which has, I think, developed, has become more common is not just in salvage situations, but in patients with severe reflux, is effectively diversion with a Roux-en-Y bypass. And that, of course, will minimize the issues of gastric emptying because the stomach's, the proximal pouch is tiny. So you're not really relying on gastric emptying. And at the same time, it's a very low pressure system. And I think that, that is a valid salvage option if we think there is significant delayed gastric emptying. We don't often see it high on our sort of thought processes as an option, but physiologically it makes sense to have something which has excellent stomach drainage combined with a low pressure system and an exclusion of most of the stomach juice and bile. What do you think about it's a little bit radical, I suppose.
I think when there's good evidence for it, it's good. There's evidence for it in patients with dysmotility, systemic sclerosis, as a revision option. As you say, there's no chance of relapse. So I think there are a lot of pluses. It's a bigger operation, and I think it's particularly useful in people who are overweight. I think if they're overweight, it's a no-brainer because I think it sorts everything out in one go and cures their diabetes and sorts their reflux out, and they end up being happy afterwards. In other settings, it's more difficult and it's a patient-related discussion. But you and I both see patients, all the time. We've had 1, 2, 3 Nissen applications, and they're back again, and that's not a good position for the patient either. So it's informing the patient and working out what they're prepared to undergo, and whether they know that there's a chance in 10. You showed your graph at 10 years, 40% have got symptoms again. Are they willing to have another operation 10 years down the line? That's the question, isn't it? Yeah.
And I think one thing that we've now realized also is that when we do it for reflux Roux-en-Y bypass, they need the similar guidance as patients who are having it for obesity surgery, in the sense dietetic support, nutritional and vitamin support. I think that sometimes when we do it for reflux, they've not passed through that sort of route. But when I do it, I think it's important that we advise them as we would any bariatric type patient, because they will need the ongoing guidance and nutritional supplements.
So Kinesh, as you started this, I'm going to just finish off with just a question to you. I mean, we did one of these webinars just on traditional gastroesophageal reflux, and Phil Woodland presented a very, eloquent algorithm for how you treat reflux patients and so forth, and how you subclassify them. But no one seems to want to take ownership of LPR and throat symptoms. What do you think is needed for us to get to that same position in terms of having that test, treat algorithm that we need for patients with throat symptoms that are going to make a difference?
That's easy. That's an effective treatment. The reason no one wants it is because it's difficult to treat. And that's why, there are I had 3 identical slides of, the head and the hands. That's the reason. So it generates a lot of work, but there's no clear consensus on what to do that actually is meaningful. So, we've given us PPIs. We now know that that's not helpful, particularly if there were a clear dietary strategy, if there were a clear medical or therapeutic option, guided maybe by diagnostics, maybe not, then that would be a game changer, and people would welcome those patients because they could offer them something meaningful, and that's satisfying for both the patient and the doctor.
Okay, great. Well, we're going to wrap up there. So thanks for everyone for joining. As I say, we'll send a link round for anyone who wants to watch this offline. I just want to thank Kinesh and Marcus for giving up their evening. Much appreciated, and hopefully it's going to raise some debate, and it certainly is going to help me focus where we want to take our R&D efforts in the future. So thanks once again, everyone, and have a great evening, and I hope you can join us for our next one.
Thanks, Ed.
Thank you very much.
Thank you. Bye, Kinesh.